Super. So thank you everybody for joining us for this month's webinar on the Delaware Statewide Advanced Illness Planning Collaborative. Before we begin, let me cover a few logistics. This meeting is being recorded and shared. At the end of the meeting, we'll post a brief poll. We want very much for these webinars to meet your needs, and your input is how we decide if we're doing the right job here. So while our presenter is speaking, we will have all the lines muted to reduce unnecessary noise, but you are able to unmute yourself, and if you're having any trouble, we can help you unmute at the end of the presentation for questions and comments. While Dr. Dressler presents, though, please feel free to enter questions into the chat box. And now I'll turn this over to our physician consultant, Dr. Alyssa Miller.
Great, thank you, Kelly, and welcome everybody. Thanks for joining us today. Really pleased today to introduce Dr. Dressler, who's a board-certified internist and nephrologist and the Quality and Safety Officer for Academic Medical Affairs at Christiana Care in Newark, Delaware. He's been in that role since 2015, and in that role, he's engaged in initiatives to advance the clinical learning environment with a goal of improving quality, cost, and value of care through interprofessional application of high reliability principles. His current activities include leading Christiana Care's Resident Quality and Safety Council and the Advanced Quality and Safety Improvement Science Program. He works to develop bridges between interprofessional education, system-wide safety, and implementing institutional and statewide initiatives focused on the Choosing Wisely framework. So with that, we're thrilled to have him here talking today about his work with the Choosing Wisely Collaborative in Delaware. Turn it over.
Great. Well, thank you, Lisa, and good afternoon to those of you on the East Coast. Caught a quick glimpse of someone's background before the Golden Gate Bridge, and you know, as an East Coaster, our minds and hearts are out towards our colleagues on the West Coast dealing with the fires. I hope everyone stays safe. I want to thank Kelly Rand and the ABIM Foundation for inviting me to share our story about the statewide implementation of Choosing Wisely, narrowly focused towards the advanced illness planning, and I'm happy to share. So just up front, disclosures. Lisa covered a bit about my background. I'm indebted to two other individuals. One is Alyssa Miller, who will hear a video from her. She was unable to keep this afternoon free to join us, but she's been a tremendous partner in this work. She's a palliative care physician at AI DuPont Hospital here in Delaware, and a colleague of mine from Christiana Care, Loretta Consiglio Ward, who's a safety and quality education specialist. Without them, I would not be here this afternoon. So the objectives of my talk this afternoon is really to talk about the key components of a learning collaborative, to take a look at eBright Health's learning collaborative model for its focus on value-based care, and to evaluate eBright's current project focus on advanced illness planning. So let me tell you a little bit about eBright Health. eBright Health is a strategic partnership of 5 Delaware hospitals, typically known as competitors, to increase the access of healthcare services and to improve the quality and affordability of care that we offer all Delawareans. And it also strives to be the pinnacle of health for Delawareans by sharing best practices in population health strategies and innovations to raise the quality of care. So why Choosing Wisely? To fulfill the mission of eBright Health, I was asked, based upon work I've done in the past at Christiana Care, to develop a statewide initiative that focuses on avoiding wasteful or unnecessary medical tests, treatments, or procedures, all with the goal to promote better care and higher efficiency. So what we did at the outset was you can see the eBright Health umbrella and the 5 organizations that comprised eBright Health at the time. We sought other partners in our community to partner with in order to accomplish these goals. And in year 1, we chose to focus on antibiotic stewardship, which is one of the reasons why you will see certain organizations on the right Quality Insights, as an example, in that year was very focused on implementing CDC guidelines about antibiotic stewardship. As we advanced into year 2, we focused on advanced illness planning and imaging and lower back pain, which is why we included organizations like Delaware Hospice or the American Cancer Society. And year 3, we focused on preoperative testing, what we fondly call drop the pre-op, which is used elsewhere, both north of the border and in the United States. Because we recognized as healthcare systems, we can't do this work alone. And obviously, I just want to call out on the lower left-hand side on the right is ABIM, who, working with Kelly and Dan Wolfson, has been really integral support in helping us do our work. So for those of you who may be less familiar with components of a learning network, and there are many references at the end of today's talk for those who want to learn more, there are 3 basic pillars of a learning network. One is you need the conveners who develop a structure to do the work. Secondly, you need participants. And then third, you need to learn. And so under the convener category, the convener will choose the topic, they'll assemble expert faculty, they will create meetings, both face-to-face and teleconference, and maybe today they're all teleconferenced. Utilize a model of improvement, work with the groups to advance their efforts, and then measure. The participants are also equally important. And there you have to develop local leadership in order to move their teams locally in between meetings. And in our world today, we recognize that providers alone don't hold the keys, and it really should be an interprofessional team predicated on the problem you're trying to solve. The participants need to have an understanding or need to be directed to do a current state analysis, collect local data, and then with that, they have the necessary ingredients to figure out how to move forward. And then you need to learn. We are very big promoters of the all teach, all learn mode. This slide was written in a pre-COVID era. And I think even in a COVID era, once we can do it, in-person learning sessions are always valuable, while Zoom and the like have filled a niche, and maybe we were reticent to change before. I think many of us still yearn for that in-person contact. You need to give teams individual action periods to implement and to experiment. And I think one of the 2 most important elements are flexibility to adapt at the site level. If we take a look at all the organizations within eBright Health, we have tertiary care systems with that approach 1,000 beds or more, and we have small, more critical access-oriented hospitals without the depth and breadth of bench. And we can't come in and tell them how to do things. We have to help them see how to do things with the resources that they have and do it in a way that they want to move forward. And then lastly, the most important factor is that networking capability. And I think we'll hear a piece of that in Alyssa's comments a little bit later. So in year 1, when we first started out in this work, we asked our question, how are we going to be successful together? So we decided to adopt the structure that I just reviewed with you. And you can see how we did that very specifically for antibiotic stewardship. We chose a topic that we felt was generally safe, that everyone acknowledged was an opportunity. We had CDC national data to know where Delaware performed in this. And we set up quarterly face-to-face meetings. We had facilitated monthly teleconference calls with the team leaders from each site. We developed a toolkit using the IHI model for improvement, ABIM, found the foundations, choosing wisely, toolkits, and also tools available from Quality Insights as they were trying to work towards implementing CDC guidelines. And at the time, our only measurement was really at the state-wide and very delayed. We had no direct measurement capabilities. And the other the other pillars were the same as before, where we worked with our individual organizations and their teams to get up to speed and move forward. So back on August 9th, 2017, we kicked off. We had our chief physician executive of Christiana Care get up in front of the group, talk about the importance of this work and how this was going to be a new day in the state of Delaware where competing organizations were working together. We had Kelly Rand to come down and give us a national perspective. And we had several direct application breakout sessions where we had the groups commingle and we taught them about process improvement, barriers, stakeholder analysis, and we had a lot of robust reporting out so we could all teach and all learn from the collective groups. And then in December was our second face-to-face meeting where we had Cindy Bowe, the Chief Strategy and Business Development Officer from Nemours Children's Hospital, and we brought in Dominic Russo, who at the time was the Director of Health Partnership at Consumer Reports. And again, we had our direct application breakout. Meeting 3, we had our senior leader from Bay Health, Dr. Gloss, talk to the group. And we had Julia Simzek, a PhD from University of Pennsylvania, who really was developing expertise on antibiotic stewardship and the patient decision-making and how do we do that better. And then lastly, we ended at Bay Health with Gary Siegelman, their Chief Medical Officer, talking to the groups. And there we had an expert panel from Laurie Hicks, who's from the CDC, talking about our work and how it supported the work the CDC was doing. And then we rewarded all of the teams and recognized all of their efforts. One of the tools that we developed for them is, you see a small snapshot here. It was a Milestone assessment tool where the team self-assessed using a survey monkey how they were doing in meeting various milestones along the course of the time. And then we would project how they were doing, kind of to create a congenial competition amongst teams to move them forward and know who was doing what, when, and where. Here you can see an example of the milestone progress report, the one on the top at the beginning where everyone was red, and then and then at 3 months, the colors started to change from red to green. And then at 6 months, you can see ongoing migration around the 4 domains, whether it be pre-work, background, or measurement, or methods, or implement, measure, adjust, and sustain. And we found that to be a useful tool for the teams to get a sense of how they were doing it in their effort. Here are just some quick snapshots of the toolkits that we provided them. On the right, you can see materials from Choosing Wisely directly, and on the left are some of our adapted tools from the IHI improvement model. And this is a bit of an eye chart, and my goal here was to show you that one of the outputs at the end of the initiative was we had a project management tool that we gave the teams, and then my colleague Loretta put it into an infographic program that created these wonderful graphics of how the teams were doing. These were printed out and they were roughly 3 by 5 feet. And we gave them to the group so they can post them in their organization and use it as a conversation to highlight the work that they had done in their organization and what they were able to accomplish. So we took that very successful year 1 and we were challenged by leadership to saying, well, if you do 1 a year, it's going to take 48 years or longer to adopt everything within Choosing Wisely. Can we do more than 1 at a time? So we decided to do 2, and we chose these 2 based upon work that was taking place in our ACO around radiculopathy and how best to manage lower back pain, and how do we manage our end-stage COPD and CHF patients better. So we kind of adapted our work to meet those goals so we can have more alignment. and we came up with advanced illness planning and imaging and low back pain. And now I'm going to speak more specifically around advanced illness planning, and this is where Alyssa was supposed to pick up the talk, but we'll forgive her, but she'll tell us more about that. It turns out in the state of Delaware, like I'm sure many of your states, there's been work at the state level around end-of-life care, and there was the Delaware Health Commission did commission this work back that was presented back in March 2016 about the end of life. So we knew that this was a goal that the state would be interested in as well. Additionally, there were best practices that were developed within the ACO around palliative and end-of-life care. So we wanted, again, to leverage these tools and align resources in an attempt to be more effective. So, you know, with the state's needs and the goals needs, as I had mentioned, we felt we had perfect synergy. We additionally opened it up to local community organizations, Delaware Hospice, as well as one of our healthcare systems, which is not part of eBright, but we like to share, and we brought invited St. Francis in as well. So the project design for the overarching project design was that each organization could individualize what advanced illness planning meant to their organization. Again, this is tipping our hat and recognizing that each organization is in a different place in the conversation. So a one-size-fits-all model would not be collaborative or helpful to everyone. Each site had to identify a single project leader or champion, so that way the work would go on in between meetings and each organization would figure out how to move forward. We aligned it with state and ACO goals, so that way the hope would be those resources would help each team to be successful in an area that is not directly articulated that I'm aware of, and I'm sure Kelly will say otherwise, in the Choosing Wisely framework, but we felt that this was a great project to promote wise choice of care utilization. And, you know, one of the things that we talk about with our teams, you know, in my work as an educator at Christiana, as well as with these, is that change is hard, and these projects are about managing change. And we frequently refer to the Nostr model here, which talks about the 5 necessary resources to bring around change: vision, skills, incentive, resources, and action plan. And I'm sure as you take a quick look at this, you can see what happens if you're missing one of the 5 critical resources. So we talked to them about that, and I'd have to say that one of the common missing links for our teams are frequently resources. We tend not to work in a resource-rich environment, although I know there's variation across organizations, but we know that that's an ongoing opportunity. They had the vision, they had the skills, they had the incentive, but resources frequently was a challenge, particularly around data acquisition. And we advocated for organizations to develop smart AIM projects. Here are 2 of them, one from the Christiana Care team and one from BB. We try to follow rigorously process improvement methodology, so that way teams can move forward. And then here are the other 3 organizations from the eBright LLC and their opportunity statements. So they got very specific around what they wanted to accomplish. When we take a look across the organizations and what were some process improvement approaches they used, there were everything from a learning needs assessment to drive provider education, to building relationships to drive referrals, to embed palliative care within subspecialty clinics, and to work to include palliative care in daily patient care workflows to improve access. And I think if you sit back and look at these and think about them a little bit more deeply, you can see that this I think is representative of where different organizations are in their internal conversations, as well as their approaches to process improvement in general. I won't go through every line here, but very similar to year one. We started off with our Chief Population Officer at Christiana Care to kick it all off. Through the different leaders through the various meetings. We brought in two external experts, one Gwen Darian, to bring in a patient perspective and patient advocacy to inform the group, and then Scott Halpern also from University of Pennsylvania to really talk about decision making and how to hardwire that type of decision making for both clinicians. And then we ended with Dan Elliott, our Senior Medical Director of the ACO, to talk about the importance of that work. So on these next couple of slides, I'm going to give you some ideas of outcomes, and not at the actual numbers, but you can see that everyone or most of the groups tried to get to very specific data and tracked it within their various means and capabilities, from a run chart, if you will, to a pre-post, to just data of numbers of patients flowing through the system and what was accomplished. And then, one organization, their data was that they opened an office, they got a grant, and they had a goal for referrals. So again, each organization was at a different place. And then here are 6 projects and their various lessons learned. Not for you to memorize, and obviously you can kindly look at this after when you get the slides. But really, there was rich learning and a lot of similarities and challenges in implementation of these projects, because these are real life projects, not in a perfectly controlled environment. And then we still felt that this was a success, because each organization had something more at the end of that year than it did at the beginning. I'll give you a peek into our 3rd year, which was Drop the Pre-Op, which I'm sure many of you are aware have to do with diagnostics and imaging for low-risk patients before low-risk surgery. What we didn't realize that COVID-19 is a strong intervention to decrease elective low surgeries and related pre-op testing. But what we're now learning, it's not a sustainable strategy, which is a good thing. But what we found is we still had our team leaders meeting through COVID, even though all their work related to this project ceased, because the benefit of networking and the partnerships that they developed, even in the few short months, was very helpful for them to work through COVID. They learned from one another. They wanted to get together every month to share. And I wouldn't have expected that from the get-go. Similarly, we've developed a sustainment arm to our prior year's projects to try to keep those conversations going. Doesn't look quite the same as the main project. We have them come to our quarterly meetings and try to get them to do the work in between hand. I think what I'm beginning to understand is key success factors is they still need to have a leadership champion, because without that champion beating the drum, so to speak, then interest rapidly gets lost because people are busy doing other things. It's really great to have a statewide team, because together they work better. And what I'm also finding out is having an anchoring organization. And what I mean by that is the antibiotic stewardship group really coalesced around Department of Public Health and their hospital-associated antibiotic, or their hospital advisory committee, and using them as the central organizing organization, or excuse me, anchoring organization to keep that conversation going. We have the Delaware Coalition to try to keep the advanced illness planning together, and we're trying to work through our radiation safety committee at the state level to see if they can be that centralized hub to keep anchoring this conversation. We're more than happy and capable to have them come back every 3 to 4 months to keep them moving forward, but I think we don't have the bandwidth to do all of it at this point in time. So here I'm going to segue, and we're going to have Alyssa Miller share her thoughts about the Learning Network. And so I'm going to stop sharing so that way Kelly can show us a video.
Great. Well, welcome. We're so pleased today to have Dr. Alyssa Miller here with us for a brief cameo appearance. Dr. Miller is a colleague of Rob Dressler, and she's the Division Chief of Palliative Medicine at Nemours AI DuPont Hospital for Children, part of the Nemours Children's Health System. She's also a Clinical Associate Professor of Pediatrics at Thomas Jefferson University, a Fellow of the American Academy of Pediatrics and the American Academy of Hospice and Palliative Medicine, and the head of the Delaware Choosing Wisely Collaborative's Advanced Illness Planning Initiative. Dr. Miller received her medical degree from the University of Rochester and completed her residency and fellowship at the Children's Hospital of Philadelphia. We're very pleased to have her here today. Again, she's a colleague of Dr. Dressler. And if you could start maybe, Dr. Miller, telling us a little bit about your work on this project, and then maybe tell us what's been your best part of being part of this work.
Yeah, absolutely. Thank you for having me. And I'm sorry I wasn't able to join you in real time on this webinar, but I'm really excited to be joining you in this recorded video. So my work, I joined the eBright Health Collaborative that you've heard all about from Dr. Dressler. I joined partway through the first year. And as the first year of that first antibiotic stewardship project was ending, and we were looking for the next project, advanced illness planning and a palliative care type project made a lot of sense. And what didn't make sense to people was that the only hospice and palliative medicine person on the group was a pediatrician. And so we talked a lot about how to make this work, and what would a pediatrician be doing running an advanced illness planning project, and how could we really make this work for all of the hospitals in the state. And it ended up being a phenomenal project, as you've heard all about, and really a great experience. I would say that the best part of the project and the best part of the work was getting to interface with my colleagues in palliative medicine throughout the state. So all of the health systems that Dr. Dressler discussed coming together, finding a project that made sense for their local environment, and then still working together to teach each other the lessons that we were all learning locally, to be able to spread those lessons and share them across different health systems, really was incredible work. And I think it's changed the way we practice palliative medicine in the state. I think we now have each other's cell phones, and we call each other much more often, and much more consider each other to be close colleagues, despite the fact that we don't work in the same health system. So that was absolutely the best part of the work.
Great. And you've talked a little bit about what changes you've seen and how this work has continued through this close collaboration. Any other changes that you've seen that you've been able to see sustained?
Yeah, all of the health systems that were involved in this project were really committed to continuing additional efforts when the one-year project ended. I think, unfortunately, a lot got derailed by COVID, which was the reality for many of us, that we had to change our focus, and many still have their focus very directed at COVID. But the hope is that things are settling down in our state, and as we are able to focus again on other things, that this group will be able to come back together and really continue the work. And so I was pleasantly surprised that people wanted to continue when the one-year project was over. And I'm excited that in the coming weeks to months that we can get back on track.
Great. And speaking of COVID, have there been any other implications or impacts of COVID-19, particularly around this palliative care work?
Well, I think the palliative care community nationally really came together very quickly to help support each other, help create templates for some of these difficult conversations that we were having with families that were in some cases very new to a lot of folks, and then really learning how to quickly spread and share our knowledge and do just-in-time training for a lot of our colleagues in other fields. And so COVID has certainly affected the conversation around advanced illness planning. We saw a lot more patients coming in and asking questions right off the bat because they knew how sick they or their loved one could get and how quickly, and wanted to be able to have those conversations. So certainly I think advanced illness planning as a concept has moved by leaps and bounds in the last few months in our country, and the conversation really has changed. And then I think one of the really positive challenges for the national palliative care community is going to be how to continue that momentum of these conversations in a good way, to make sure that folks are having conversations with their loved ones about what they would want for them if they are unable to speak for themselves.
You know, the silver lining of sorts of this terrible pandemic. But thank you so much for your work. Anything else you'd like to share before we wrap up?
No, I just think the idea of working across an entire state and across health systems who are typically competitors, coming together to work on one single idea and one single project sounded ludicrous to me at first, but it worked so well. This learning collaborative was really amazing, and certainly I think worth a try in different geographic areas throughout our country.
Great, super. Well, you guys are an inspiration. Thank you so much. Thanks for joining us today.
Thanks for having me.
So thank you, Lisa, for that interview and getting or allowing Alyssa to share her thoughts about that. You know, the one thing, oops. You know, the one thing I want to say before I cover kind of the specifics of this slide is that these local teams did their work based upon what they saw in front of them. And, you know, one potential interpretation is that this might have been health systems attempting to drive referrals. I think another way to look at this has to do with the fact that the clinical space is very busy. Clinicians don't perceive they have the time that it takes to have some of these important conversations with patients and their family. So how do we best engage the experts and obviously work with patients and families to engage in these important conversations? So I think that's important to understand, and just want to make sure that there are alternate ways to think about that, especially if in my comments I may have stated in one way that it felt differently to others. So, you know, the Learning Network take-home message is it's a reproducible intervention that works broadly across clinical topics. You're really able to integrate wide range of acute and ambulatory care centers, everything from academic and community health systems, ambulatory clinics and medical aid units, as well as community organizations. It allows you to set up a process to meet organizations where they are, and allows everyone, even the big expert centers to the smaller community-based centers, to teach one another and learn from one another. You never know who may have the key that unlocks a door that you're having challenges opening. And it allows you to define and measure meaningful impact at the level of the institution and across the state. All that remains elusive to date. So those are the end of my prepared remarks, and I'm more than happy to entertain and have questions with the group. So thank you for your time. Lisa, how are you?
Yeah, great. Well, thank you so much. That was a great summary of some pretty incredible work. So with that, we're going to open it up to questions. I don't see a nice shout out from Dan Wilson. Great work. But anybody have questions, you can either use the chat function or you can unmute and ask questions directly. I'll give it a minute. I've got a few things at the top of my list, but we'll see if anybody has questions.
Hi, this is Jill Hutt. I work with the Greater Philadelphia Business Coalition on Health. We serve employers in southeastern Pennsylvania, Delaware, and southern New Jersey. I work with Neil Goldfarb, who many of you may know. And I'm glad to just have attended today, and certainly want to thank you for a fabulous presentation, and congratulations on the great work you're doing. it's very important to our coalition and the employer purchaser community that we represent to see this kind of work being done with choosing wisely and so forth. So we thank you for that.
Well, thank you for your kind words, Jill. And whatever we can do to help promote the conversation, feel free to reach out and we'll figure out how to accomplish that goal.
Wonderful. Thank you.
Mm-hmm.
Great. Others? So Daniel Wilson, what special sauce was used to create collaboration among competitors?
That's a great question, Dan, and thanks for asking it. It's really kind of interesting is I think competition is at senior leadership level. When you start getting a little bit deeper into an organization, even one that's relatively flat from an organizational structure, most people want to do the right thing and they want to learn and they want to do better for their community. So the secret sauce was maybe not to have the leadership in the room, except for, kind of christening the ship, if you will. I think that's the secret sauce.
Great. Others? I have a question about the topic of palliative care. I think, there's where we bear some level of scar and trauma in this country about issues of, palliative care, more end-of-life care and low-value care and costs, right? So did you run into that issue at all? Nervousness, hesitancy, people saying, geez, we can't have this conversation about low value care because of the concerns about skimping on care, or we're, denying care. And I know that is not the intent of palliative care, but just because of the, shall I say, the old death panel trauma. There, I said it.
So,
did that come up at all?
That came up and comes up. I'm not going to try to speak for Alyssa or any other palliative care experts, but I can surely wear the hat of a nephrologist who has been part of many conversations with patients and their family around understanding wishes and what the right care is. And I think the best way to frame it is what are the goals that the patient and family are trying to accomplish. And I think in general, approaching any conversation about unnecessary care, low value care, potentially patients and families start saying, oh, you're just trying to save money. So it's really a focus on what are your goals, what's the best way to get there, what's the most appropriate way to get there, and try to address it through that lens. But I know there are other Choosing Wisely experts in the call, and happy to have them add substance to my response.
Others with thoughts about that?
I think one of the compelling things about palliative care too, in talking about costs, is that at least particularly one of the Choosing Wisely recommendations around palliative care actually costs more, but is better care for the patient. So one of the recommendations around palliative care is that you should hand feed rather than use a feeding tube at the end of life, particularly with patients who may have mental acuity issues. And I think one of the compelling things around that area is, though I think we've heard less about death panels as time goes by, is that it is about patient safety and giving people the best care. And I think most people who really understand palliative care understand that it really is grounded in that that clinician-patient conversation about finding out what that person really wants at the end of life.
Yeah. Well said. Thank you, Kelly. What does the patient want? What's their goal, and what's the best way to get them to that goal, without cost being part of that conversation? They'll have better quality of life. It will therefore be high value to the patient, and it's not per se about what is the cost of delivery of that care.
Great. And then I'm also curious, so I asked your colleague the question about COVID and what that did, since it's disrupted so many initiatives. But how's that impacted you, Rob? Do you want to say any more about that?
Well, I'm working from home a lot more. But so this work continues. We just had our first, we called it all hands meeting, not face to face, a couple of weeks ago, to kind of get drop the pre-op work back up again. We've extended the time window. We traditionally used a year, which was completely arbitrary, and then trying to understand what we need to do to help support the teams moving forward. So we had our first meeting a week or two ago, and actually tomorrow we have our team leader conference call and really working on trying to get them moving forward. We are experimenting with ways to measure, and we're going to ask teams to validate some of the information that we have, and then see what happens. Simultaneously, I know you can imagine the antibiotic stewards people were completely halted their work because they were focusing on all their infection control and infection prevention pathways around COVID and pandemic. We're going to start re-engaging them. I think they're looking for a little bit of breadth of conversation at this moment. And re-engaging with our imaging colleagues around trying to find that anchoring organization to help kind of keep the conversation going. So there was a lot of things put on pause, but we're now beginning to stand that back up again.
Other questions or thoughts? Okay. Well, maybe a wrap. Kelly, other thoughts from your end, or anything in closing, Rob, for us?
No, for each of you that are on the call, in whatever way you touch high value care, thank you for being a champion for that cause in your work. No one individual, no one organization holds all the keys, and it takes this collaboration and learning together and sharing of information to know how to do it better, or to try a new solution in your local community. So I want to thank ABIM Foundation for their support and their constant effort to bring people together to share, to learn, and to advance this important topic.
Great, thank you. Well, you guys have done an amazing job, so thanks for sharing that with us today.
Yeah, thank you. Thank you so much, Rob. A great presentation and just phenomenal work and inspiring work on end-of-life planning in Delaware. And an awesome insight into how states and competitors can work together to better care. So if you haven't noticed, there is a poll up. We love to find out what you think about our webinars. Our webinar for October will be on October 20th. And so thank you all for joining us today. Thank you again, Dr. Dressler and Dr. Letourneau, for the great conversation and your great presentation. And have a great night.
Thank you.
Yeah. Bye-bye.
Bye.
Thank you.